on behalf of BAOMS and with Lanko, who's the president of BAOMS elect for next year, I'd like to welcome you here. This is a day which is aimed and been put together, aimed primarily at the surgeons in training, so the SPRs, people doing core training, and people on the doing second degrees. What I want to do, it's quite a dynamic time with things are changing, and we've been through quite a rough time in the last 5 or 6 years in our relationship between oral surgery and MaxFac. And I would like, in this day, to bring you up to date with some changes that are coming through commissioning, which are quite dynamic. And so I would like you to get this information direct, because actually within 4 or 5 years, you are going to be the consultants who are managing these processes. And you're going to be the dynamic ones, the ones running with it. And you really mustn't come into your post with any baggage. You must see it and very clearly of how to go forward. And what I'd like with today is to just discuss and hear how these changes, what is happening, what is envisaged. So there's very short talks of 15 minutes, followed by 15 minutes discussion, ranging through the commissioning process, then on our relationship with academic dentistry, through the dental schools, which traditionally that's where we've been positioned, and what's going to happen in the future. And then hoping Nigel Stansfield will be here to talk on the medical side and postgraduate deans. And we've got a deanery input from the dental side. All of these which are going to have impact on how you run your practices in the future. So there's an insight into the future, I'd hope. This is a day that's all to do with information. It's not to do with aggressive questioning, anything like that. This is all to do with learning and understanding. So to start off, Sue Gregory who is in the Department of Health, has been taken ill this week. Unfortunately, she's had a health scare, and so she's not going to come today. She phoned me up a couple of days ago to say that it's likely. But Colette, who she's worked with on this general project, has her slides and is going to actually present her talk. And so you're going to get a double whammy. So can I ask you to start off, if you don't mind?
Well, good morning, everyone, and thank you very much for the invitation to speak to you today. And as Marcus just said, I'm standing in for Sue Gregory on this slot. And Sue, within the last 2 weeks, has become the Director of Dental Public Health within Public Health England. We've had a huge reform in the NHS, so bear with me if you feel some of this is dry, because really it's an opportunity for you to learn firsthand what has happened and how the structures are starting to form. So it's been a very, very busy transitional time. NHS England has now assumed the responsibility for the commissioning of all dental services via the national and area teams. It was a steady state transfer. They wanted a really smooth transition, and we won't begin to feel that single commissioner for dentistry and for all specialist services for a few months to come. Public Health England, as I've just mentioned, is up and running. And local professional networks, if these are all terms that are new to you, hopefully this introduction to them will sort of start to get you thinking about how you may interact with them and start to understand the structures. And recruitment to those local professional networks is just beginning. There is a need, and certainly at the area team of the NHS in Greater Manchester this week, it was very much the message: we need to build on achievements that are already in place. This isn't to start again on everything, but to build on where it's been excellent, look for variation and try to level services up to the best, and to do that quickly. The context for all of this, and I don't know if many of you will have seen this publication, this was the NHS Commissioning Board, as was, just before it moved to be NHS England, and it set out its vision for how it intends to commission excellence in dental services. It proposes a care pathway, whether that's in primary or secondary care, And I think that's now so embedded that that's a given. A care pathway approach is what we're moving to. And there'll be a focus on commissioning across the whole system. And I think if you think about commissioning in terms of understanding what needs there are, what resources we have to address those needs, and then delivering models of care that are effective and efficient and evidence-based, you're going to feel more and more that that's the approach that's happening across all services. There's an example of this, and again, it may be in the preventive world, but Delivering Better Oral Health was a publication in 2007, and it set out to distill the evidence and deliver a sort of, this is what's a must-do guidance. And that's now in its third revision, and we could see publications like that and resources like that cutting across the whole dental space, so that for treatment areas as well as advisor areas, that we get the best evidence that there is and actually produce it in a format that clinicians can easily and effectively use within care pathways. Of course, because it's now across the whole commissioning structure, the future dental contract reform in primary care will have an impact on specialists in secondary care. And again, the Department of Health are piloting at the moment a care pathway approach in just over 100 practices in England. And this, I don't know if many of you know about the details of that pilot, but again, it's a personalised clinical care focused around the needs. So for the first time really in dental primary care, the actual needs of a patient are collected at the beginning in a needs assessment. And then the outcomes, did that oral health picture improve, is reviewed at the end of the pathway. And it's focusing more not on the numbers of fillings or the numbers of extractions that were done, but what were the outcomes for that patient. So that's a type of care pathway approach that very much links through to, if that's level 1 care, when does it become level 2 and when does it become level 3? And when should primary care contractors be making referrals? So it's trying to bring a consistency and an effective use of resources across the whole dental space. And they're working on that new contract at the moment. But I think, again, a given will be the care pathway approach and needs-led care pathway approach. So we're going to start to see this type of approach across from primary care through to specialist services. Just to give you an example of that type of consistency, these are just little examples of self-care plans. And there's a medical history form which collects a certain data set. And rather than every practice do it differently, in the pilots, they're collecting it in the same consistent way. So again, if there's excellence, it's adopted and shared and used by everyone. So we're starting to see a single way of doing things. And again, this has been very helpful in the pilots for cross-practice working, for understanding the data sets because they're the same, and we've got a consistency of data capture. And that's the type of consistency that we'll start to see introduced and shared across England. But while the Department of Health have been working on primary care reform, and the commissioning has now transferred to the Commissioning Board, or NHS England as is now, the Department of Health will very much set the policy, i.e. a care pathway approach, effective use of resources, evidence-informed care, and it will be for the Department of, to the NHS England to design those pathways and to implement the models of care to meet that policy requirement. And as I've mentioned, there'll be a steady state, but very, very quickly, these new organisations will establish themselves, and partnership working for clinicians working within provider units, in specialist units, will need to make these connections and understand the importance of key organisations such as Public Health England and Health Education England for training purposes. And, you know, I think keep your eye on the space. It's quite a complex picture, but very quickly they'll start to communicate out. So within the last 2 weeks, the NHS Commissioning Board, a special health authority, became NHS England. And I think the importance of having one single commissioner for the whole of England represents a huge opportunity for dentistry. It's probably a once-in-a-lifetime chance. Previously, 2 years ago, we were working with 152 primary care organisations that were commissioners, all with their own variations of skills. Some were very good at the task, others that fell below what might be expected as a commissioner of specialist services or primary care for that matter. So their vision, they've outlined it in their operating model. As I've said, Securing Excellence in Commissioning Primary Care was published in June as the commissioning board, but NHS England completely adopts these models, and Securing Excellence was published on February this year, and it might be worth, it's not a difficult read, for people involved in your sort of later stages of training to really get interested in this is how your services will be commissioned in the next decade. Clinical leadership is mentioned throughout this. The importance of clinicians becoming involved in this type of work and seeing its importance can't be overemphasised. And starting to form service redesign and care pathways across the dental space from primary care to secondary care will be an important role for clinicians to start to engage with. Let me just explain a little bit about NHS England's structure so you're clear. And it's been described to me a bit like if you imagine Sainsbury's. If you're in a Sainsbury's anywhere in this country, you recognise the organisation you're in. It might be a Sainsbury's local or a big hypermarket. This is how NHS England want to be branded. It's one organisation. They have 4 regional teams, but it's all NHS England, and 27 area teams. They don't have a chief exec or a board. The only board is within the central Leeds district area of NHS England. And these area teams have a director, and it's very clearly one organisation with one way of doing things, and everyone is working for that one organisation. That feels probably not a big difference to some of you, but if you imagine that those 152 primary care trusts each had their own board, had their own decision-making powers, this one commissioning board has a much better opportunity to take a bird's eye view of England and start to think about specialist services and the whole dental space in a very different, probably more intelligent way. The area teams' relationships will be with the local providers, but their direction and approach and commissioning tools and frameworks will be produced by the national NHS England. And they've published what they see as the commissioning system will be delivering, and very much focused on sound finances. Would be in cloud cuckoo land if we didn't think that value for money doesn't just mean the lowest price, but getting the very best for the resources we have, not allowing waste or poor models of care to be getting in the way, so that we can deliver the highest outcomes and the best clinical care that we can for the resources we have. I mentioned earlier local professional networks, and they're an integral part. The dentists who will be employed as the clinical chairs of these groups will be accountable to the most senior clinical person within the area team locally, but they're all professionally accountable to our Chief Dental Officer, who's Barry Cockcroft, and he will be professional lead in NHS England. They want clinical leadership at the heart of that, so that one person being a chair of a local professional network is clearly going to have to work through the local networks, very much needing to involve specialist clinicians in those, to start to work with them to get the local implementation of national frameworks. It'll be a common purpose, and it'll be grounded within those national frameworks. And there's a real chance here, if this is something that interests you, it's at the beginning stages to get involved and to start to find out locally where your networks are developing and get involved. This sort of three-eyed model is a sort of, at the core of that local professional network, in the yellow sort of circle, will be the chair, the clinical leads. And then there's the second model is sort of where I think the specialists and leaders play in. And what the whole system is trying to do is influence the wider providers, whether that's in primary care or specialist units in provider units. It'll be different levels of people engaging at different times. But we want the local professional networks to be influencing clinical leadership across all providers. About 2 years ago, the 152 PCTs merged into 50 clusters, and now we're down to 27 area teams. They're defining and securing those clinical leadership teams at the moment, and they need to make use of that clinical leadership. So they need to be very clear about the priorities that are coming out nationally, and there is a real message not to lose that excellent engagement. So if there's things that you've been working on already, they're going to build on that, and you probably need to make sure it's connected into that local professional network system. And it's all still aligning, so it won't happen. They're not hitting the ground running. A lot of this still has to be established and set up, and different areas will work at different paces. The scope of dentistry is very complex. The whole of the NHS Commissioning Board will have to take account of services from providers, from primary care, from dental hospitals, and almost 700 million from specialist services in hospitals. So it's a huge task, and it isn't something that's going to be changed overnight. So steady state is definitely the message. I think coming back to commissioning, what it's all about is understanding and addressing need. And I hope later, when I start to share with what we've been doing in Manchester, understanding need has not been addressed well for us in specialist care or in dentistry. To start to work on improving outcomes, we have to start collecting outcome measures rather than process measures of the number of activities or the number of ops, to taking a much greater focus on actually what were the outcomes of that care provision. We know that there's inequalities in access, inequities in who gets the care, and they want to definitely promote more patient and public involvement. You must all be aware the Francis report is really starting to influence what's happening at every stage of health service planning. And I think something that we will see is swift adoption of something that's excellent. It'll be validated quickly and could be shared across England very quickly. Up to this, it's relied on publications, perhaps just meetings like this where things are shared, and then you've got to take it back to get that locally implemented. If there's one commissioning board with decision-making powers, we could very quickly see, just as we did in the pilots, this is the standard medical form, this is what we need to collect, and this is how you do it. And I think we should get adoption of excellence more swiftly covered. The task will be for all of the dental specialties to produce what's been called a commissioning guide. What is the specialty? What does it deliver? How do we assess the need for it? How do we know what excellence looks like? How do we measure outcomes? And so on. And there'll be one for each. These are just the front covers. And the one that they're working on as a tester is oral surgery. So this one is in a draft form. It's very soon it'll be ready to come out for consultation. For people like this group would be an excellent group to have a look at that. It's going to describe what the evidence is for the procedures, what levels of care we would expect, what qualifications, what standards we would expect. Because up to this, there's been primary care providers, what standards, perhaps 152 different ways of doing things in the PCTs. They want to see excellence delivered regardless of setting, and the same outcome measures are used regardless of setting, so we can start to make some intelligent decisions about how services are offered and see quality driven up across the settings. So just in summary, the new organisation, NHS England, is less than 2 weeks old. They want to see improved health outcomes as defined by the outcomes framework, very much working outcomes. People's rights under the NHS Constitution, their right to have appropriate timely care in the correct place at the correct time with someone with the right qualifications and the correct quality settings and standards. And patients and public will have more choice. Perhaps we'll see outcome measures being published by providers. And clinicians really, they want to see have greater freedom to innovate, to swiftly adopt things that you've heard about rather than having to go through lots of layers. And having one commissioning board making decisions on your behalf, there's a real opportunity to do that. And they want to address some of the inequalities that we've seen in healthcare. So in summary, it's very challenging. This transition has been enormously challenging. It's probably the greatest reform to the NHS since its inception, but considerable opportunities to get involved. And I think the future is yours to shape it. Many of you are in training. There's a real chance here for you to change legacy services, focus on quality and outcomes, and that's what's going to matter most. Thank you.
Thank you very much. It's now open for questions, and I'd like to just start out. I pick up this as a dynamic time, and actually, and I said to you before, everyone envisages how things are going to end up, and quite frequently they never end up the way you exactly want them to. So there's going to be an adaptation in this. I still don't, you haven't really come out with a vision of where MaxFac integrate into this. And is this going to be, there's not going to be a major policy, it's going to be left to each regional area for the people to make the best service they can in that area? Is it going to be left to local sort of areas? How do you think?
I think what's going to happen is that there's going to be a commissioning board, NHS England National Board for Dentistry, that's going to be led by Barry Cockcroft, and it's going to be co-chaired by someone called David Geddes.
Okay.
I think when I put those sort of specialty guides, they'll come to each specialty in turn. It hasn't been written yet.
Okay.
And I think when they complete oral surgery, MaxFacs might be one of the next ones to have a look at. But being a medical specialty, the CCGs will have an interest there. So I wouldn't want you to have the impression that it's been written or decided yet. Yeah. I don't think that's the case, and I think it's the opportunity here for people to shape that. They'll want to know what the specialty regards the future, but it'll link in very much with what happens in oral surgery.
Yeah, I know, absolutely. Any questions from Christoph?
I would like to just some clarification. As oral maxillofacial surgeons, we certainly do procedures which are more in the medical field and other procedures more in the dental field, like oral surgery we provide. I mean, the majority of oral surgery is provided still by oral maxillofacial surgeons in this country. So is it thinkable that part of our work will be commissioned by the clinical commissioning boards and part of it will be commissioned by the national board, or will we be pushed out into to a different corner? What is your view on that?
I haven't got a view. I can just tell you what I know about conversations that happened at the time that Securing Excellence was being published. They looked very carefully at trying to separate out MaxFacs as a medical specialty because that would be commissioned by the CCGs. It was almost impossible to disentangle the units, who even down to the individuals, who was providing oral surgery services, who was providing MaxFacs. So the decision was taken pragmatically to take the whole thing into the NHS England single commissioner. And there's a line in Securing Excellence that says very clearly, at some point, if it's appropriate and deemed to be supportive to this specialty, the CCGs may be devolved, the medical specialty part of MaxFacs, at some time, and no time scale was put on it. Because I think these discussions haven't been fully understood. Another thing that's very difficult is that the activity data, the information is not robust enough to start to make these decisions. So I think we've got to clean that act up before we can take decisions about what goes where. And considerably more work needs to be done. So it's a decision that is pending but not been taken.
Yeah, Ian?
Ian Hutchison, apropos what you just said, it's very difficult to tease out the difference between oral surgery and maxillofacial surgery, and that is actually we're all oral and maxillofacial surgeons. So everybody in this room is an oral and maxillofacial surgeon, and 80% of the work that we do is oral surgery. It's only the 20%, it's the more complex stuff. There is light on the horizon because BAOMS set up the National Facial Oral and Oculoplastic Research Centre, which has data sets already started. And that I've written to Barry Cockcroft and Sue about it, and to Bruce Keir as well. Because you may want to use that in the data that we're collecting and commissioning, and ultimately looking at primary care dentistry, because the British Orthodontic Society are joining, the oral microbiologists are joining, and maybe other dental specialties will join the National Facial Research Centre. And they, ultimately you're going to have to revalidate dentists in primary care. Your big problem isn't going to be the hospital stuff, it's maintaining excellence in primary care. And you may well have an opportunity to do that through something which was set up by BAOMS.
I think the message coming through right now is that it's very fluid, it's very dynamic, and if MaxFac groups react by disengaging, you'll lose a huge opportunity to integrate and become an active member in these teams and maintain a link through with dentistry and the referral base, things like that. So this is not the time to put your hands in your pockets and sit in the corner. It's a time to actually get involved locally and make it work for you in that area. And I suspect it's going to be quite different in different parts of the country. We were talking before, and we can see conurbations, the Londons, the Birminghams, etc., having similar patterns. But actually, as you get out into areas where geography plays a big part, the chances are the services will change quite a lot in those areas. Patrick?
It's a small point, and Alistair knows my feeling on this from before, but both in the dental commissioning book and in one of your slides, you refer to maxillofacial surgery. And of course, there's no specialty of maxillofacial surgery in the UK. We might call ourselves MaxFac for short, because it is a big mouthful. But it's disappointing when government documents and dental documents consistently fail to recognise that, as Ian said, and as you said before, that the specialty is oral and maxillofacial surgery, and it's that because we're oral and maxillofacial surgeons. 150 of the people currently in the oral surgery specialists are oral and maxillofacial surgeons. So it's a bugbear, and it sort of worries that there might be a misunderstanding of what we actually do, and it happens repeatedly. And it's just a shame to see one of your slides with that on it again today. And it hope that.
Alistair, did you want to respond?
Well, I wanted to ask a question.
Yes, come on.
I was just wondering, for the future consultants, and in deference to Patrick, in oral and maxillofacial surgery, what are your 3 take-home messages from these changes?
First of all, apologies to you. I absolutely take that point, and I'll share that back with Sue. I do understand that, and I'll make sure that it doesn't happen again. The 3 take-home messages, I think in the last gentleman's comments, it isn't about our problem. I would very much put the responsibility back to clinicians here to start getting engaged, just as you've said. I think it is a dynamic and changing time. Look for the opportunities rather than the risks to hold you back. And I think perhaps when you come to look at maybe some of the Manchester project, the difficulties and successes we've had there, some of the third key point might be to really start to work on robust needs assessment and outcome measures. That would be my strongest message to clinicians.
Yeah, the interesting thing is that, I don't know if Bruce Keir's had a lot to do with this, but things are going right down a data route. And Sue was telling me that actually all the practices are going to have to collect data, and that data is centralized and stuff can be pulled out. So it's all very much that model of cardiac care, etc. That's all starting to go into primary dental care. And it's data that's going to be driving things. It's interesting, because it's something that we've cottoned onto as well. We've been trying to match on the different aspects. Okay, if there's, yes.
Could I just ask a
Austin.
question? Austin Smith, Sheffield. Could I just ask, the area teams you've put up there, and you've clearly defined what you do. It's not clear to me, although I've read some of the document, at what stage of preparation they're at. And secondly, in a practical sense, how do we get involved with them? Because I'm not aware of any invitation or sort of consultation document that's gone out to the existing service provider to say get involved in the new structure.
As I mentioned, they'll each have their own director, so it tends to be in a sort of cluster form. So, for example, Greater Manchester has got one area team. They are starting to have go-live events. They're less than 2 weeks old, so they're very much focused on computers, desks, people actually coming into post. I think you'll quite quickly start to realise who the area team are, because it's the area team that will have the interaction with local providers. But I don't think we'll see much of the national framework starting to come out now until the National Commissioning Group for Dentistry is set up. So I think at this stage it's watch and start to understand what's happening locally, and keep a view on that National Commissioning Group, which I hope Barry Cockcroft will share across the specialist groups with what's happening. And as they turn to each specialty, they will involve the leaders of those specialist groups.
Okay. Yes.
Sorry, it sounds to me like the local area team doesn't have much powers from your presentation to change things. It's the people in Quarry House and Leeds. So our engagement with the local team, in a way, is not going to be fruitful.
I can see
And
how
I couldn't get from your presentation how would the people in Quarry House listen to us and who to talk to. As a specialty, we are worried that you might take away 70% of our work. but we don't know who to talk to, and the local team is not clear, and from your presentation, you don't have any powers.
I hope you haven't got that impression. I can understand that you suddenly think there's 27 local area teams that don't have as such decision-making powers. But I think I made clear that those local teams will be the ones who interact with local clinicians on the ground. If there is excellence, it'll be shared very quickly. So it'll be local clinicians influencing what the frameworks look like. It's not going to be a group deciding in Quarry House. It's a very different structure to what we have at the moment, and I think those local area teams will have quite an influence with what is shared back and what's implemented locally. It's just too early to say how it's going to look and how it's going to be shaped. I'd just be, I think, crystal ball gazing at the moment, but it certainly isn't the intention that the decision making will just be Quarry House and people will be told what that's not how it's being communicated.
How are you going to measure our excellence?
How are we going to measure excellence? Well, in the commissioning guide, that should be worked on by leaders in each specialty, will say, what does excellence look like in restorative dentistry or oral surgery? This is how we're going to measure it. And then those measurements will be applied consistently across England so that you could actually benchmark. At the moment, we've got no consistency.
Okay. Okay, chaps, we're bursting into life here.
Hello, thanks for an excellent presentation. One area of the minor oral surgery looks like the little is done.
Sorry, I didn't.
The minor oral surgery, the oral surgery part. Is there any qualifications, has it been planned? What sort of minimum qualification one should have to perform oral surgery? Is it been done already?
When I said it was in a final draft form, you have to start somewhere with these. So the Securing Excellence group established a little subgroup which had oral surgery clinicians on that. And we've started to ask them as commissioners, how might you measure an outcome? We showed them what outcome measures were in other specialties. It's very much a starter for 10, so that something's on paper, and then that commissioning guide in its draft form, the new commissioning group for dentistry will start to take that through all the specialist organisations so that people can consult it, look at it, comment on it, and try to get a consensus of how we measure, describe what qualifications you need. One of the parts that I can think particularly was setting out a specification for if oral surgery is provided in its primary care setting, what standards and quality of environment, equipment is required. And that's been an area that I think has been quite poorly commissioned. And what level of qualification should be there, what level of supervision should be in place, so that we don't see isolated practices providing oral surgery without any controls or supervision. So that's the type of thing that's starting to form, but very much a draft
It's
framework.
forming up, and we can feed into that, I suspect.
Absolutely.
Yep. Sorry?
Satish from Manchester. In the last 20-25 years, NHS has seen about 18 reforms. Now that this reform has already started, have we given any time span for this to work? Or are we just going to hope that it will work and at some point we will start with another reform?
I have
That's
so
the
much
fear.
empathy with you. I think it's my 13th. I've been in the NHS since the 80s. Really show my age here. That's my 13th reform. So a change is a constant. And but I think this
is
one
the big one.
feels different
This is the big
to
one.
all the others. They felt like they've played around the edges. This is entirely different.
This is all about, to me, it feels completely different. At each one of these, we're going to be held up. If you're doing skin cancers, how are you doing it compared to the next one? It's going to be comparison to drive up standards. And when have dentists collect data before? Never.
Okay.
Now,
Needs assessment, yeah.
everything's going to be data. I think this is a biggie, and they're not going to go away from it. Sorry, Tom.
Yeah, my name's Tom Walker. And quite a lot of people in the room, I can't tell you an area of the country I'm from or my job because I'm actually in the middle of this long training. And I think it's something that, almost in this sort of, to paraphrase John F. Kennedy, like we can give you a lot, because not only are we working in dental hospitals and primary care and in hospital services in oral and maxillofacial surgery, we're also in casualty and general surgery. And in terms of patients' needs, in sort of formative and comparative, expressed and felt, we're able to tell you maybe before the data is available, what patients need, you know, when they turn up to casualty at 4 in the morning with a sore tooth, and what they're getting at dental school. So I think we can, as a specialty, be very helpful to this process.
I couldn't agree more, and I think that the one thing that's changed about this reform, and I hope it's not words, is that they want clinicians in control again. I think there's been far too much commissioners and managers working and then letting clinicians know what they've planned. I absolutely agree. I don't think we collect needs very well. We don't describe the impact of poor oral health. And I think people at the front of it, like yourselves, have a huge amounts to offer. And I think that's why I keep putting back, but you have to take the responsibility to do so and see this of interest and of importance.
Okay,
To come back to something-
one more and then we'll just move over. No, it's quite
you
important.
talking about commission involvement. I was president of BAOMS last year, you're president this year, and it's really a question for Mark. I'm not aware about ever having been asked to sit on this advisory oral surgery group as a specialty, which I think was a remiss of preparation. Have you been asked to sit on this advisory group?
No, but I'm not that nervous about it, because I genuinely believe this, is that what they want to do, they can't do without us. It's just not going to work. It's going to be a mess. And actually reputations are sitting on this. And so we are going to engage. The biggest error is us not wanting to engage. That's the message. I think we can affect these documents.
I'm making a different point, Mark. I'm making a different point. I'm making a point that we've heard we want to involve clinicians. We are clinicians, and we're clinicians doing 80% oral surgery, and we weren't invited to participate.
Let me just comment on this. Try and think, this organisation only established less than 2 weeks ago. They didn't want to just start and then start working. So they've been doing the big conversations, the big thinking in the background as what underpinning work needs to be done. They're now established. They've started frameworks, outline frameworks. The next stage will be linking into the specialist. They didn't have any authority, or they couldn't assume a responsibility they didn't have. It's a new organisation, they've done some thinking, and the work begins.
I apologise, Nicola. I misunderstood what you said. I thought you said that you already had an oral surgery group working giving advice.
We involved some clinicians to sort of test out how might it be.
Right, so you did?
No, but the board, when it establishes the commissioning group for dentistry, will start to do that formally. We weren't an organisation, we just started to try to do some thinking. So different people, commissioners on the group, thought we'd just involve a few clinicians to try and test out clinicians working at the beginning. It wasn't formalised, it now needs to be. The Department of Health did have an advanced care group working, which involved all the colleges, etc., as I understand it.
Okay, last one, because we've got to move on. Rob, do you want to just quick?
So I apologise, I came in late. Rob Epping, the chair for OMFS training in London and clinical director for Major Trauma Centre in London Network. I've been seconded for the last year as part of specialist commissioning in London for rehabilitation, so CRGs and the rest of it are sort of second nature to me. But coming back to Ian's point there, as a director for major trauma, there is a national clinical reference group, so there are 96 other CRGs for all of the specialist services, for which now I understand this will be one. And that was put open to, all of those chairs were interviewed on an open basis through NHS, and all of the members of the CRGs were actually interviewed in a competitive process. And the idea is exactly as you say, and I come back and I reiterate what Mark said, is this is about actually the CRGs will set the standards, they will set the benchmarks, it will all be peer reviewed, and it's those that will then go forward into your local area teams that will then dictate about what it is in terms of competency, in terms of outcome measurements, in terms of standards for training that will actually be there. So I just wonder where you would see yourself as a CRG in relation, say, to major trauma or to endocrine services or such and such. Is it the intention that there will be a national clinical reference group for this specialty service?
Again, I can just give my own opinion here, but I think I did say in one of the slides, and that Sue put out, we're going to build on excellence. So A commissioning guide, as I would see it, if there's something out there that's excellent, that's been developed, as you say, that would just be lifted and dropped.
Yeah.
Why repeat the work? And as soon as the board come to each specialty in turn, those connections will be made. And what's there and excellent and can be validated to be outcome focused will be lifted and used. There's no need to repeat work or not to sort of use what excellence is
Absolutely.
out
So,
there.
so
Yeah.
the question is, will there be a clinical reference group for
I
OMFS?
can't answer that. That would be a question for the
Well,
chair,
I'm
Barry
suggesting
Cockcroft
that
and
will
David
probably be
Geddes.
the way to actually make sure that peer review setting standards and competencies.
I don't
et cetera,
disagree.
will work together, as it's been for 96 other clinical reference groups for other specialties.
It makes sense to me, yeah.
Okay. I think, this is my view of it, is that in fact we're integral to this process, and there's great opportunities here for us if we just work with you.